joining us for our first kickoff project lead call for this great opportunity for oral health integration. I'm so excited. Our team here is super excited as well to finally get this going, and I appreciate all your time and efforts spent so far getting all the documents that we asked for and the application process, as well as sending us the contacts to start the webinars and invites. And I want to thank Diane for helping me with that throughout the whole thing and taking the brunt of all the emails for me. So this, like the invite said, this is the first project lead kickoff meeting, and we, as mentioned before, we expected just basically the project leads to be on this call, but you're more than okay to welcome somebody else if that's the case. But we are recording this call in this webinar, so you are more than welcome to share it with anyone else later, or distill it however you want, or we'll send the slides, of course, afterwards, so you can have those too. There's a slight modification to the agenda where basically our team from Qualis Health will have a little bit more time to describe their role and talk about the framework. Also, something that I just had to address last minute, which is I did not send any attachments prior because we are still working on the data use agreement, and Qualis will talk about it a little bit during the call, but I will follow up with everyone afterwards and send that out for your approval and signature. Also, the project timeline is going to be embedded in the presentation, so I'm not sending any special document for that, but we will send you updates as the timelines changes for whatever reason, so you'll have those throughout the project. Again, I want to start by welcoming everyone, and we'll go through some introductions really quick on our end. And please, when you do introduce yourself, just quickly your name, your role, which clinic you're from, and and anything else you want to add for this project role. Here on this side, I have myself. I'm Mohammed Ali Ajuri. I'm the project basically manager. I'm the integration manager for OPCA, Oregon Primary Care Association, and
hi, good morning. It's Irma. Irma, the Director of Primary Care Transformation here at OPCA. I am thrilled that we are kicking off this project of putting the mouse back into the body. I'm excited, and thank you for submitting an application and joining the work.
I am Diane Lechner. I'm the TA project coordinator, and really excited to be working on the oral health initiative as well.
And that stands for training and technical assistance. So she'll be basically, you'll be seeing Diane's emails a lot more than mine probably, because she'll be coordinating most of this for us. Sarah couldn't join us. She's in another meeting, but Sarah has been the oral health manager, and she has been basically my consultant on this oral health world, and she's been great. And she'll be connecting with us hopefully. If not, then I'm sure you'll have a chance to meet her sometime soon. We have on the line also representatives from our 5 selected sites. I'm just going to name them off, and then you can go ahead and introduce yourselves. We have health centers from Benton and Lynn counties, Multnomah County, Neighborhood Health Center, One Community Health out of Hood River, and the Reinhardt Clinic from Wheeler, Oregon. So let's start with Benton County. Please introduce yourselves. Molly, can you hear us? Okay, we'll come back to Molly. How about Multnomah County?
Yeah, good morning, everyone. My name is Erin Goffin, and I more or less do project management for integrated clinical services at the health department. So I've been pulled into this integration project, which I'm really excited about. And I'm hoping we've tried integrating oral health into primary care a few times now. So I'm hoping the support of OPCA is just what we need to kind of make it successful this time and make it stick. So it's really exciting to have the support as we forge ahead in trying this again. So glad to be here.
Thank you. Welcome. Neighborhood Health? Oh, that's right. Neighborhood Health couldn't join us. They had a last-minute commitment, but I will follow up with them after this call. One Community Health?
Hi, it's Elizabeth Ogney. Can you hear me?
Yeah.
Okay, good. Elizabeth Ogney, I'm the Clinical Integration Director at One Community Health. I'm thrilled also about this project, and we've had starts and stops with integrating oral health as well. And so I think that with the support and some direction and ability to kind of get us through some of the challenges, that we're really hoping to make this part of the beginning so that we can include it with other target populations at our clinic.
Great, thank you, and welcome. Good to hear you again. I think I've been seeing you everywhere this last 2 weeks, so it's great.
I know. Nice to hear you too.
And then the Reinhardt Clinic.
Hi, this is Carrie Scott and Marge Joza. I'm the Director of Quality, and Marge is our CEO. And everything that everyone said, we're right on stage with that. We are so ready to integrate oral health into our primary care.
Woohoo! Yay! Thank you so much. Molly, can you hear us now?
Yes, can you hear me now?
Yes, go ahead, please. Welcome.
Okay, perfect. We were having technical difficulties here. I am Molly Perino. I am the oral health supervisor and project lead for the community health centers of Benton and Lynn counties. And we're diving into integrating dental into primary care, and I'm excited to get some new ideas and freshen things up and get people on board. So I think this will be great.
Great, thank you so much and welcome. And we also have our partners from Qualys Health, which they'll go into a little deeper dive into their role, but I want them to introduce themselves as well at this point.
Hello, this is Catherine Phillips, and I am the Program Director for Practice Transformation and Oral Health Integration at Qualys Health. Glad to be here today.
Thank you for being here.
And this is Jeff Hummel. I'm the Medical Director for Informatics and Practice Transformation at Qualys Health, and I'm happy to be here too. It's nice to hear so much enthusiasm among the participating clinics.
Thank you.
And this is Mary Verdon. I'm the lead consultant for the oral health work with OPCA, also with Qualys Health, and I'm from the Kansas City metro area.
Great, welcome.
Hi, this is Bree. I'm a project manager, and for the OPCA project, I'll also be assisting with technical assistance coordination.
Welcome, Bree. Thank you all. Anybody else that we've missed on the call? Okay, moving right along. So, as the agenda stated earlier, we're going to just basically, this is the kickoff call, an overview of the project. I'm not by any means an expert in oral health integration, but I hope with your help we all become experts in this and present great findings. But Qualys Health, our partners, will discuss the specifics of the framework later on during the call. But I'm just going to go ahead and go over just some basic ideas about oral health and integration, just from my work so far and meeting folks and the professionals that I've talked to in the literature. And just so some of you may not really have dealt in this world as much, but we'll go through it together. And the first thing is, what is integration really? And I think that's been a key question for all of us here because it means a lot different to many people. And the common definition has been basically it's just coordinating care for the patients. And it's a systematic way of coordinating this care, where traditionally it's been the PCP or the providers have been seeing our patients for the clinical needs, specifically the body needs, and there's been a return movement to integrating oral health, behavioral health, and any other services that have been sort of not in the traditional primary care setting. So, and also the definition comes back to this whole concept of a whole body care, and one funny quote that I heard in a recent conference was putting the mouth and the head back in the body, because it should have never left to begin with. So now we're bringing it back. And then other ideas that I've been hearing about integrating, I've talked about HIV/AIDS patients to integrate their care into primary care, the LGBT community and the patients within that community, and then any other populations who are really integration doesn't have to be of disease-based or health services, but also integrating populations into the primary care and making it comfortable for those folks to be included. Another question that comes up is, well, why would we want to integrate? The professionals and the experts really talk about the medical home model as kind of the latest innovation in healthcare. It's not so much innovation anymore. It's now standard pretty much. And that really brings the idea of the home health being the whole body and a team-based approach to improving the health and enhancing the patient experience and controlling the cost of care as well. And so as it relates to dental or oral health, actually, we talk about dental care and oral health being the most common unmet health need in our populations here for the community health centers. And so it just made sense to start with that as a piece of work for integrating that service. Also, patients are more likely to go see their PCP, not the dentist. So if we can implement some of those basic preventions at the PCP's office to help out with, with mitigating some of the dental issues, the oral health issues, then it definitely makes sense. Again, putting the mouth and the head back in the body as where it belongs, where they belong. So just a quick overview of this project, and please interrupt me if you have any questions, and you can use a chat box or just ping us. This project is essentially a 2-year project, between 18 months and 24 months. It's funded by the DentaQuest Foundation. However, as I mentioned in the Memorandum of Understanding, we will have to reapply for year 2 as a formality with DentaQuest, and we'll do that in the late summer. But basically, it's and the work itself for this year, for this planning year 1, is about 10 months for the clinics, for the health centers. We had 2 months of pre-work already from August and September, and then now we're kicking off in October. So this is the 10-month period for this year. And then you'll get updates throughout the project as to the timelines for year 2 once we have that, and then also the status of the year 2 planning. Again, we had 5 clinics, community health centers selected. It was a really fun selection process, and unfortunately we had limited spots, so we had to decline a few applications, not because of anything specific, but we were trying to shoot for representing geographical diversity, the oral health being present in the practice or not, the population selected. So we went through several factors and criteria before we came up with the 5 finalists. So congratulations to those of you who are on the call for being selected. We're excited to work with you, and I'm sure you guys are, have been planning for this for the last few months. So finally kicking off is great. We're going to utilize a framework. It's an evidence-based framework that Qualys Health will describe in a few minutes for this project. So it's not, we're not making it up as we go, although we will make adjustments according to the needs and specific unique areas of the clinics to make sure that we meet the basics. And then, of course, expectations that there will be some workflow redesigns. There are going to be things that you'll have to do that you haven't done in the past in primary care, including some different team members, of course, and just the idea of assessing and providing those oral health services within the primary care setting. That's going to be unique to everyone, I'm assuming. I'm hoping that from that we learn best practices going forward. Just a few more things. This framework is also going to result in a publication of a series of resources to help other primary care practices across the country, and Qualys Health is going to partner up with DentaQuest on that. I'm hoping they'll explain more on that later, how to call. Again, the project's goals are develop workflows, improving referrals and care coordination for the patients, improving communication and engagement among the medical and dental staff and teams, training the primary care teams to screen patients for oral health risks and problems, provide education, prevention, and just triage for appropriate care as needed. And then also leveraging the health information technology, the EHRs, the EMRs, dental record systems to basically come up with the best workflows and also to extract data when possible. And that's sort of the technical aspect of this project. Again, with this partnership, OPCA is helping to partner with the clinics and Qualys Health, of course. For us here at OPCA, we're hoping to provide robust learning collaboratives. There's 5 of us, 5 organizations, basically a network of great minds speaking about this very same project and sharing ideas and best practices. We will provide coaching support and access to the resources and the experts, content experts, technical assistance, as mentioned earlier. We will facilitate and lead the monthly webinars and also coordinate the face-to-face meeting in December, which I'll talk about in a minute. And then coordinating and facilitating the basically the test the field testing that Qualys Health will talk about in a few minutes as it relates to the workflows in clinic. And we'll talk about that more later as we move on. The content experts, of course, will have access to, so we will, whether it's via the webinars or content that we send via emails, or even as you progress in this project and you have questions, we will be more than happy to dig around and find expertise for your needs. Any questions so far about any of this?
No, I don't.
No.
And as far as the role that the community health centers will have, again, you probably have seen all this already in the document sent prior, but just to go over again, we expect that you provide or identify a provider champion and hopefully an executive sponsor as well from the team. Project lead, which hopefully are on the call today, or leads, could be more than one. The pilot care team is essentially the team that will be conducting the care, and so that could include any of the clinical roles or non-clinical support roles that you have already in practice. And then the implementation team, which is an extended version of the team that includes the QI folks, the data folks, EMR experts, EHR, or even the project managers. That's hopefully the culmination of the entire team is working together. And some of the webinars, actually most of the webinars, will be content-based. So we do hope that any team member joins, but we are requiring that at least the care team is in attendance because it's content-heavy and it really has to do with the workflow and the actual work that we're going to be doing together. You're also supposed to identify target population. I think a lot of you have. I think all of you have identified it through the application process. Participating in the scheduled learning webinars, as mentioned, the monthly webinars, the face-to-face, and then there will be some follow-up phone calls post certain activities during the project. And of course, the data submission that we've mentioned throughout this experience so far is really crucial that we start as much as possible as we are able to, basically based on our systems and our resource allocation and availability of resources to pull the data, and so we can use that to guide the rest of the project and also for the findings. And as I mentioned in the documents prior, there's going to be basically forward data collections for the year, and we'll start collecting data in January. And if that sounds alarming to you or intimidating, please don't worry about it. We will work with you on identifying the barriers or figuring out ways around the systems if that's going to be a conflict, basically, on the system requirements. And also, we have a good relationship with OCHIN. I know many of you are OCHIN partners, so we will work with OCHIN on figuring out ways to help you extract that data. Another thing that I didn't mention here on the slide, but I'm hoping, if possible, if time allows, for me to connect with the project leads and talk about project charters and successful project management. If you need that sort of assistance, please let us know, and we will definitely facilitate that sort of training if needed. I think it's important to have a project charter. It really guides the project throughout, and expectations are met early on for the entire team. The specifics of the data and metrics are in this slide here, and we've kind of talked briefly about that. But basically, if your system allows it, or there are ways around the system, maybe manual data entry or gathering, we would like these required process metrics to be collected. And percent of patients given the written verbal assessment, and then based on the assessment, a percent of patients given an oral health screening exam, percent of patients given a referral to a dentist, and then percent of patients with a completed dental referral. Those are the 4 required clinical process measures. And then you get to choose one of these following intervention metrics. Percent of patients given oral hygiene training, percentage of patients given risk behavior education, percentage of patients given fluoride varnish or other fluoride therapy, and percentage of patients given medication change to prevent or address dry mouth. Again, all these metrics, the required ones and the additional ones, are within your targeted population. It's not your entire population, just to make that clear early on. And again, like I said, please do not have that be a point of anxiety, the data piece. We will work together on finding the best possible options to get that data or work around it. And if there are no other questions, I'm going to hand it over to Qualys Health, our partners, to talk about the framework and introduce that team more in depth. Any questions so far?
No, I don't think so.
Hey, Catherine, it's all yours.
Thank you. And are my slides up? Everybody able to see those?
Yes.
Yes.
Yes. All right. Excellent. Thank you very much. All right, well, we'll start here with a little bit more on introductions. For those of you who don't know us, Qualis Health is a nonprofit quality improvement and population healthcare consulting organization. We're based in Seattle. We have the opportunity to partner with the Oregon Primary Care Association, the Oregon Rural Practice-Based Research Network, and two of the sites on the phone today, Multnomah and Fountain Linn County, earlier on the Safety Net Medical Home Initiative. Since 2007, our team has focused on helping primary care practices adopt a patient-centered medical home model of care. And we really see this opportunity for oral health integration as a continuation of that work. Just as Mohammed said, to achieve the promise of whole person care, to improve the way that we deliver comprehensive care. You heard from our team already. I'll share just a few tidbits about them so you have a chance to get to know them. They'll be supporting the Oregon Primary Care Association and your centers over the next year. Jeff Hummel, our medical director, is also our health information technology guru and will be a great resource to all of you on that topic. Mary introduced herself. She's been the lead PCMH coach for sites in oral health integration in Kansas and Missouri. And before coming to Qualis Health was herself the administrator of the University of Kansas School of Nursing Safety Net Clinic, and she was responsible there for leading their practice transformation efforts and helping them achieve recognition as well. So great on-the-ground experience. Bree is our fearless program manager. She also helps prepare research reports, resources, tools, and whatnot, which we hope will be of use to you. Oral health integration is actually a new topic for Qualis Health. Our foray into this was in 2014 when we were selected by the National Interprofessional Initiative on Oral Health to lead a new project, Oral Health in Primary Care. And the goal of that project was to prepare primary care teams to deliver preventive oral health care and to improve the way they structure and the way they support referrals to dentistry. The concept, the process we use for this work is very much based on what we did on the Safety Net Medical Home Initiative, which was first to develop an organizing framework to identify what could be done in the primary care setting to protect and promote oral health, and then to test and improve it, and to back it up with tools and resources so that practices in the future would have what they need to make this a reality. We began by conducting a literature review and looking at results coming out of efforts to integrate behavioral health services, which, just like oral health, were once fragmented, but are now really recognized as a key component of providing comprehensive whole person care. We also convened a technical expert panel to guide us, to advise us, and that included primary care and dental care providers, practicing providers, leaders from medical, dental, nursing, physician assistant associations and the professional academies, payers and policymakers, as well as a patient and family engagement expert and advocates in public and oral health. We convened this group and we asked them a question. What do you think it will take to change the standard of care, to make interactions like you see here on the left, where a provider is looking into a patient's mouth, just as likely, just as common in the future as those on the right are today, a provider listening to a patient's heart. And this very diverse, very broad group of people came to three things. First, we needed to provide a really clear definition of what could be done in the primary care setting to protect and promote oral health.
That hadn't been clear in the past. Second, it had to be a very streamlined process for fitting oral health into what we know is already a jam-packed primary care workflow, right? These activities are being done into addition what we're already doing for behavioral health and general chronic illness and preventive care. And third, we needed a new and a practical model for how primary care providers and teams could work together with dentists and their teams. All right, so that practical model. We addressed these items in a white paper, Oral Health, an essential component of primary care. That was published in June of this year, so just a few months ago. I hope you've all had a chance to see it. If not, I'd encourage you to read it. There's an executive summary as well, the short points. It includes the case for change, sort of why oral health as a clinical topic should be a priority for primary care teams. It includes the oral health delivery framework that we'll talk in much more detail about today, and also some case examples from early leaders in the field. Primary care practices that had already done some around oral health integration. They shared their experience, their lessons learned, sort of what made this work stick in their setting. And two of them, Confluence and the Child and Adolescent Clinic, are community health centers, those both nearby in Washington. We certainly recognize for oral health integration to be feasible for primary care writ large, that primary care practices are going to need support. And so we also in the white paper make a number of recommendations to stakeholders, dentists, payers, educators, and many more about actions they can take to support this into the future. The core component of the white paper is the oral health delivery framework. 5 actions that our technical expert panel identified that primary care teams can take to protect and promote their patients' oral health. All things that are within the scope of practice for primary care, and all things that are possible to implement in diverse settings, meaning they do not take new or additional members of the care team, don't require specialized equipment, space, or anything like that. The oral health delivery framework is what we'll be testing together, and so I'm going to ask Jeff Hummel to come on and share a little bit more about Jeff, are you on?
Let me see if I'm unmuted. Can you hear me now?
You sound good. Yep, you sound clear.
Okay,
take it away.
I was double muted there. Okay, thank you, Catherine. So the oral health delivery framework has proved to be a very useful way of breaking down what could seem like a hugely complicated task of a bunch of unknown things that we're in primary care being asked to do, and getting it into a very sort of bite-sized and sequenced set of actions that a primary care team can really do. Because as far as assessing oral health in a patient is concerned, and we see these patients all day long in primary care, there are a number of things that we can learn about their risks for both caries and periodontal disease, which are the primary conditions that we're concerned about, particularly in the populations that you've chosen. But we can ask questions. We can understand what, so the questions that fall into the ask and the things that we look at, the decisions we make, the actions we take, this is what primary care does all day long. So we're not really presenting anything new. And any of you who have any clinical experience will immediately recognize that this is the same set of components that the primary care visit is broken into, the SOAP, subjective, objective, assessment, and plan. We actually think these words better describe what happens, but this is not a new way of thinking. I think it's the important thing to understand for primary care. If there's anything new, it's the fact that we all now have gone through at least 5, and in many cases, many years more of electronic health records, and hopefully are becoming comfortable with documenting each of these sequences in our primary care work. So as we turn our attention to what really gets asked, we started out with a large number of questions that were potential, and we realized immediately that you couldn't ask the care team to ask 20 questions about oral health. We've narrowed it down to about 5 questions, and they basically are questions about a person's diet, because we know that the amount of sugar and carbohydrates that a person eats, particularly in snacks, is a major factor for caries. We asked about how often they brush their teeth for 2 minutes using a fluoride toothpaste and floss, how many days per week that actually happens. And that gives a good objective measure as to whether one is practicing, the patient is practicing standard, or the recommended standard, I should say, for oral hygiene. And then we also have a question that we recommend the patients be asked about any pain or bleeding when they brush their teeth or try to eat. And there's a couple of additional questions that can be asked. These can obviously be tailored to a pediatric age group to get much the same information. Looking in the mouth is really a matter of teaching the primary care team to be comfortable actually making an assessment of whether the teeth look normal or there are signs of caries, whether the gums look normal or there are signs of inflammation. Many times we'll find that providers will say, I've never looked at the teeth, I don't know what to look for. But providers are good at, I mean, this is not something that's new. It's the same physiology, same anatomy, same immune system, same circulatory system and nervous system. And these are things that providers and their care teams can quickly do. Then once that assessment has been made of the asking and looking, then they can make the decision. And the decision really boils down to, is this person at increased risk for caries, and the other decision is, does this person have signs of caries or signs of periodontal disease? We are not asking clinicians to make a diagnosis. Dentists will tell you the only one who can make a diagnosis of caries and periodontal disease is a dentist. And whether that's accurate or not isn't the point. We're not asking providers to make that decision. We are asking, though, for them to say, is this normal or is it not? And we're giving them parameters to make that decision by. And then the actions really involve the preventive things that we can do in the clinic, many of which are coaching and counseling, teaching, dietary education, and application of fluoride. We've been doing that for years in the pediatric age group, and but caries are just as prevalent in adults as they are in kids. And fluoride, varnish, is just as effective in adults as it is in kids. Documentation is a challenge because the electronic health records that we're using, by and large, do not have places to put the answers to the questions we're asking or the findings that we're seeing when we look in the mouth into structured data into the EHR. We're developing a number of workarounds for that. We can talk about this in more detail later. We're in active discussion with OCHIN about modifying the user interface to accept that information. But at this point, we have ways of workarounds. So, Catherine, let's go to the next slide. So we've learned as we go. I mean, this is our mode of operation. We do learn as we go, and we modify what we're presenting to people and how we present it as we go, because this is not something that we were smart enough to figure out in its entirety going into it. One thing we've come to the conclusion is that it's not a good idea to separate the ask and look. Teams get confused. They may break those tasks up for different care team members. The medical assistant may do the asking, the provider may do the looking, but to think of those as two different steps gets into the realm of, well, we only look if we found something, if there was an abnormal question or answer to a question we asked. And we really tend to think of asking and looking as being two sides of the same coin of doing a oral health screening assessment. And to be perfectly honest, this framework that we've, it's very simple, it's accepted as the way primary care works, is actually, we've adapted it for other diseases as well, because this is, what we're doing here is population management. And So there's actually a third component, and anytime we're assessing a patient who's a member of a target population, that we want to make sure that the guideline-based care takes place in every member of that population, we gather information for making decisions. Is there a care gap? Is there a problem that needs to be addressed? And asking and looking are two of those, but also simply gathering additional information. Now, it turns out for cardiology, hypertension, and heart disease and things like that, there's a lot of things we need to look in the chart at things like blood pressure and cholesterol, perhaps. Now, for oral health, we didn't really see this going to oral health because there are no lab tests for caries or periodontal disease. So and it's not part of the assessment. But just be aware that the ask look for oral health is what the team does when a patient comes into the clinic. The decisions, as I alluded to earlier, fall into two categories. They fall into risk assessment. A person may have perfectly normal gums and perfectly normal enamel on their teeth, and yet be at very high risk for getting caries or periodontal disease because of some behavior, such as snacking multiple times a day or having energy drinks that they're sipping on all the time, or not brushing their teeth. That's still a risk factor, and the action then follows from what the risk factor is should result in an action to address that risk factor. Likewise, the other thing that the decision is made, as I mentioned earlier, is the presence of active oral disease. And once again, these fall into two categories. They're both chronic infectious diseases. The dentin and enamel, we're concerned about caries, and with the gums, we're concerned about periodontal disease. Treating this and even diagnosing it accurately is not in the knowledge domain or the treatment domain of primary care. This is why the referrals to dentistry are so important. But just to review why it's so important to ask about risk factors, we can adjust things in those risks. We can train people, we can apply fluoride, and we can make sure that they are armed with the right information. Now, structured referrals, that was the third concept change, or what needed to change for oral health to be really improved. And this is a challenge. It's an easier challenge to overcome when there is a dental team on site, because you already know who the dentist is going to be, and they're usually not scattered around the community. But what this really requires is that the patients who get screened in a primary care visit then get sent and turn up with diseases that the dentist need to treat, get sent to that dentist. And that this means that referrals to dentistry need to be as smooth and as structured as referrals would be to ENT. And this requires a clinical order in the order menu. It requires the logistical support that the team can provide to patients so that they know who to call, where to go to make the appointment. And it also requires referral tracking, just like any other referral, to make sure patients don't fall through the cracks and that care is coordinated. So what this means then is that communication between primary care teams and the dental teams in-house needs to be reviewed and optimized, and the communication needs to be really cleaned up so that, and oftentimes this requires, we really like the structure of referral agreements so that everybody has the same set of expectations about how long it should take and what sort of information should go with the referral. And it also requires looking carefully at the connectivity so that electronic health records, so this electronic information is shared across what otherwise would be quite a divide. So I think I'm turning it back to you at this point, Catherine, but there may be an additional slide. There is one more. This is the workflow. This kind of gives you an idea. The idea here is, remember, we're dealing with populations. This means we have to be able to see that patients in that population. It's not good enough to simply say we're managing patients with diabetes, and every time a patient with diabetes comes in, we're going to try to make sure that their oral health is evaluated. That's part of it. But the important thing is you have to actually be able to see the population. And that means you have to be able to make a list of who is in that population at any given point in time. So we're going to be working on reporting capability to actually, if diabetes is the target population, then who is in that population and how do we make sure everybody with diabetes is on that list. Secondly, you have to see the patients coming at you. I'm use that from the perspective of the primary care team. They need to be able to review the charts in advance, talk about them in a huddle, and know that this patient has diabetes, has not had their care assessed in the past year, and one of the things we're going to do today is assess their oral health with this oral health delivery framework. And that can be shared. Certainly the medical assistant can do a majority of not only the asking. In many clinics, the medical assistant can actually look in the mouth and alert the provider if they see something abnormal. The medical assistants are certainly capable of doing this, but it has more to do with the dynamics of the care teams. And the other thing we found is that the medical assistants can do a whole lot to make sure that orders get placed and tended in the order entry screen so that the provider can sign them. The orders still have to be signed, and so when the provider enters the room, they can review those answers to the oral health questions. They can look in the mouth and look at the things that the medical assistant may have pointed out or may not have. They can certainly sign any referrals, because if the medical assistant comes up with a positive answer to a screening question that requires, like pain or bleeding, that you've decided is going to generate a referral, there's no reason the medical assistant could not place and penned that order in order entry. And then, of course, the provider would update the problem list and print out an after visit summary. And then, if their resources allow, you've got the opportunity at the end of the visit for the educator to meet with the patient, go over oral hygiene training and dietary counseling. So I think that's. Let's go to the next slide.
Thank you.
And I'm going to turn that back then to Kathy.
All right, thanks very much, Jeff. So that was a quick run through of the oral health delivery framework. We'll have much more time in the future to get into that in more detail and certainly to share it with your teams. The oral health delivery framework, it's based on sound science, best thinking, this careful review of successes from the field of behavioral health integration, but it is a conceptual model. We believe it's feasible, we believe it's practical, but we want to know it is. And that was really the impetus for field testing. Right? We want to be sure it works, and we want to know how it may work differently in different settings of care. So with the support of the foundations that have come together to sponsor the national initiative, we have launched a series of field testing efforts in Washington, in Kansas and Missouri, in Massachusetts, and now in Oregon. So you are joining a cohort of 19 primary care practices. This is a mix of private practices, federally qualified healthcare centers, and other safety net settings. Some of these practices have on-site dental resources. Many do not, right? And will be working on their referral networks in the community. Just like you, each practice has identified a pilot population to begin with. Adults with diabetes, pediatrics, pregnancy, and one with all adults well visits. There's a great diversity, and that was intentional among this cohort. So we have already testing both urban and rural practices, small, large, everything in between, and also at least 5 different electronic health records in use among the group. All of these sites, you included, will receive technical assistance from your primary care association and also from Qualis Health. This will begin with some clinical content training specific to the patient populations you identify. We want to make sure everyone on your pilot care team understands the basics of the oral disease process and understands what can be done in the primary care setting to address that. Okay? The second is workflow optimization. We'll come on site with OPCA to actually work through and map out with your team in very specific detail who on your team is going to take on these new activities. When during the course of the visit will they occur? Where will the information be recorded? And what training, what support, what resources will your care team need to be successful with this work? We'll also be providing support to develop a referral network. If you do not have on-site dental resources, or if those are not able to meet what you believe will be the demand for dental care, to actually recruit dentists in your community private practice, and other CHCs if they're available to provide that type of support. Jeff mentioned that modifying the electronic health record is likely necessary to provide the type of sustainable support needed for this, and we'll help with that, as well as some of the data collection reporting measures that Mohammed had shared earlier. We'll also help provide planning for spread. We've asked each site to commit to one care team and one patient population, but we certainly hope that as you have success with this work, you'll be willing to spread it out to your practice at large, to affiliates in your community you may have, and to your entire patient population. So as we get further into the course of technical assistance, we'll work with you on a plan to make that possible. For all of this, we'll be working hand in hand with the Oregon Primary Care Association, and this will be done in partnership together. We're doing that in other states with other primary care associations, and part of the intention of that work is to help PCAs develop capacity for this work in the future. So as this initiative comes to a close, they have the skills, tools, resources they need to embed oral health integration into the support that they provide to centers in their community on other patient-centered care programs. So this is a learning project. We hope to learn with you, certainly to vet the oral health delivery framework and to identify effective approaches for implementation. Again, what do we need to know about how different staffing models may impact this? How this may look different for different patient populations with different needs, all of those sorts of things. We also want to identify the challenges and barriers that practices in these field testing projects face so we can make recommendations in the future to help other practices troubleshoot those, and certainly to improve resources and tools. We have a starting set of those that we'll be able to share with you. Things like referral agreements and potential workflows, and we want your feedback on those over time. Our goal is about a year from now, September of 2016, to be able to publish an implementation guide, a toolkit for primary care practices to showcase those tools that you all have found helpful and to provide some information to others that we hope will inspire them to take this on. For those of you that are familiar with the Safety Net Medical Home Initiative, you've seen templates for that before. We'll be following the implementation guide format there, and all of these resources will be added to that library and available in the public domain. So to do that, we're asking all participants in the project to collect and share oral health integration data, exactly what Mohammed went through earlier. And our intention there is to be able to help you in real time track your progress with this work and identify improvement opportunities, but also, as we get further along, to be able to share that information with other sites to inspire them and to help reassure them that this is possible. So all sites have been asked to collect and share that type of information. Additionally, we'll be asking for volunteers as we go through the course of the next year to share your story, your experience, what motivated you, what worked, how your teams have reacted, all of those sorts of things. Those are entirely optional. We'll put out calls as we go, and if you're interested in sharing, we'd appreciate it. If not, we understand time is limited. The same goes for resources and tools. Like I said earlier, we'll have a starting set. We'll be asking for feedback formally and informally, and we hope you'll be willing to suggest improvements, tell us what you liked, what you didn't, what you wish you would have had available in the beginning. Again, that's absolutely optional, and the timeline for that will be in early to mid-2016. We've prepared a few documents that describe this in a bit more detail. You'll receive the Memorandum of Agreement that comes from the Oregon Primary Care Association, and that lists out what you've agreed to collect in terms of data. There's also a data use agreement, and that describes who will have access to the information and how it will be used, right? It's the permission to share document. Information that will be published in the implementation guide will be reviewed by your organization in advance. There's a lot more detail in that, and if you have any questions after the call today or as you read through those documents in more detail, please don't hesitate to let me know. We're happy to talk those through with you. We've also created a reporting template and a run chart tool if that's useful to you. You're not required to use it, but if you'd like a repository for that information, we've made that available. Right? So a quick run through there on requests and data. And I know we are just at time, so Mohammed, I will turn it back to you, and I'm happy to answer any questions folks on the phone today or to follow up via email after.
Thank you so much, Catherine. I appreciate it. Great overview by you and your team. And give me 1 second to get back on here. And as I said earlier in the beginning of this call, I will be sending out those data usage agreements and for the teams to look through and basically review what will be shared and when and by whom. So that's coming hopefully by the end of this week. Any questions from what was covered so far by the Qualys team? Anybody on the call?
I do not. Sounds like a great project.
Great, thank you. And again, Qualys is really partnering with us throughout this whole thing, so we will be able to have access to them, and you'll have access to them, and it's going to be a mutually helpful environment for all of us. So just quickly, before we have a few minutes left on this call, I'm going to go over the next steps and sort of the timeline of this project. As I mentioned, this is our first kickoff webinar. However, it is not that content heavy, but the next one in October 29th to be exact, that's our first content heavy webinar, and I really strongly encourage the entire team to join, but specifically requiring the clinical care team or the care team to be on the call, because Qualys, our partners in Qualys will go over specifics of the workflows, of the content of oral health integration. And the topic of the webinar on the 29th is the case for change, oral health in primary care, and then implementing oral health in patient-centered medical home. Then on the 30th of November, a month later, we have the second webinar, and that one will be more specific to the populations that you identified. I've sent Catherine the list of populations that all of our team selected, and they will hopefully tailor the presentation to meet all those populations represented. And then, again, those are the 2015 activities. We have our first major face-to-face learning collaborative in December, and we're working on that right now. Diana's figured out details, and we will be sending out some specifics as soon as we have them for that face-to-face. It will be here in Portland, Oregon. Qualys team will join us as well. So hopefully you can block out your calendars as soon as you have some dates from us, and then we look forward to seeing everyone there. And that one is open to all teams to join, not just the care team. As far as the next year timeline, 2016, we have, again, a learning collaborative in January. We will require or request that you start collecting data in January for the submittal in April, so for the first quarter of 2016. We will have the workflow mapping sessions, and those will be sent out as soon as we have details, and that's the on-site presence of Qualys as well as the OPCA team to help go over the workflows. And that's a face-to-face event, just so you know. It's several hours in the day. Is that correct, Catherine?
Yes.
Okay. We have an interim report that's due, and I'll go into that once in a follow-up call with the team leads. And then also, basically, the data collection starts in April. So we have a few more months. I mean, it's not that many months, but I think with the workarounds that Catherine mentioned and our collaboration with Ocean, we hopefully will have something to work with that. And again, not a point of anxiety by any means.
And I'm just going to add a little additional information to that. We will work with you and your data submission team to streamline that data submission. We have heard from you that you would like it to be more streamlined than we've done in the past. So the dates chosen for data submission align with the dates that your data people are submitting data to us at OPCA. So hopefully that will be a streamlined and aligned process so it doesn't create any new reporting requirements for you in your centers.
Thanks, Irma. That's a great point. And that's why we have it January through March and then quarterly. And then the last thing I want to mention before we go for open it for questions or discussion is that we did send out the white paper earlier in the process. So if you don't have it, please let me know. We can send it out again. It's a great comprehensive look at this entire initiative and the framework, and it's a great document to share with your team members and your larger teams in your organization. And with that, I have nothing else to add. Any questions from anyone we can answer or comments? Please go ahead. The floor is yours. Okay, sounds like we have no questions, which is, I guess, great. Everyone understands it perfectly well, and we're going to get right to it. I'm excited, again, for being part of this project. Our team here is super excited to work with you all and Qualys to get this framework implemented and tested and hopefully have some great findings. I look forward to more integration projects with everyone. And then hopefully, if you guys have any feedback or comments on this process throughout, please don't hesitate to call us or email us, and we will have a great time doing this together.
Okay.
Thank you for joining us, and have a great rest of your week.
Great. Thank you.
Thanks
Thank
so
you
much.
all.
Thank you.
Thanks. Bye.